And our next speaker is Dr. Shalini Nayar. Dr. Nayar is currently practicing as both a respirologist and palliative medicine specialist in British Columbia at Surrey Memorial Hospital site and the BC Cancer Agency. She attended McMaster University for her internal medicine training and subsequently completed the respirology fellowship at the University of British Columbia, as well as the palliative medicine training program. Dr. Nayar is currently functioning in the capacity of local department head, acute palliative care program for Surrey Acute, and is a clinical assistant professor with the UBC Department of Medicine. Her interests, presentations, and publications have focused on the importance of palliative care interventions in both malignant and non-malignant disease. Dr. Nayar, it's so great to have you back again. Great to see you, and I will let you have the floor in just a second here. Let's give a big shout out, everybody.
So the objectives that I wanted to touch upon are to actually just define palliative care for everybody, so we are all talking about the same thing, and looking at certain issues that are key to COPD. Some of those include the burden of symptoms that some of you may be experiencing or may experience, or if you're a caregiver, something you may have seen, the importance of advanced care planning, and some words about treatments. The most important part is understanding the flow through palliative care services, which is often a daunting thing for people to have to learn on the fly. So we're lucky in that the World Health Organization will define palliative care as an approach that improves quality of life. And it mentions that through holistic care, physical and psychosocial, but it doesn't actually talk about a time limit, a duration of life. And that's probably the most important thing I would take away from this definition, that there is no timeline for what we call palliative care other than the recognition that somebody's quality of life could be better. Patients who are diagnosed with certain illnesses like cancer tend to get palliative care services in at a certain point in their trajectory. And so it's a very good established system. And in those patients, we were able to do a lot of studies looking at benefits in pain, advanced care plans, and even in some cases a mortality benefit. But it's less clear how that integration in chronic disease will be useful. And I think that more and more evidence has been evolving over the last decade about how that can be more meaningful. The traditional approach is like this. It's two silos: disease modification, that's called medical management, right? And that's still something that people think of together. And then a palliative approach, which means just comfort care, no disease modifying management. That's really changed over time, okay? And what we've actually learned from patients and their caregivers and from studies is that goals of care change and evolve throughout a person's individual illness. And that is different for everybody. That slope is not, you can't extrapolate it for any one disease. You have to do it for an individual. And so at any point in any illness, you may try the disease modifying approach, which is active and aggressive treatments for their medical care. But as time goes on, people change, their level of fatigue changes, their life circumstances may change. You have to keep readdressing whether or not these are treatments that you want to have all the time. And that palliative approach, which is focusing on quality of life again, right, has to evolve with it. So, they don't have to be completely one or the other. They actually evolve together over time. So is something like COPD considered a palliative disease? I don't know if I love labels. I don't think many people in lung disease do, or in palliative medicine and lung disease do. But what we do know is that when we look at the health-related quality of life of all comers, there is a suggestion that people with very advanced COPD may suffer with reduced quality of life overall, may suffer from pain management needs, may suffer from depression, anxiety, or with worsening shortness of breath. That's what dyspnea means. In one particular study done out of the United Kingdom, because the patients were living so much longer, their health-related quality of life was lower than that of patients with metastatic lung cancer. And so that's a hard thing to know, and it's a hard thing not to address. This is coupled with the fact that COPD is actually very common. It's the fourth leading cause of death in Canada, and it's responsible for amongst the highest hospital admissions. So lots of people have COPD. In the United States, it's easier to categorize who gets hospice care and who doesn't. The Canadian system is a little different because we have institutions that are freestanding hospices, and then we have a home care system that I'll describe to you shortly as well. But in the States, it's all kind of home care, and so they would define end-stage COPD as disabling breathlessness at rest, so FEV1 spirometry less than 30%, when bronchodilators aren't working anymore, when you're not able to walk further than bed to chair, repeat hospitalizations, the need for oxygen, high levels of carbon dioxide, problems with the right side of your heart, losing weight at an accelerated rate, or having a very fast heart rate. Interestingly, these criteria really don't actually correspond with any sort of timeline in COPD. So while there are definitions like this that you may come across if you look stuff up or if you want further information, I just want everyone to bear in mind that even if we look at this as criteria for hospice palliative care, many of these patients on this list will live more than 5 years, as an example, depending on how compromised they are. So it's not looking at days or months or weeks, okay? So many people have heart failure or right-sided heart failure or swelling of the legs in addition to chronic obstructive pulmonary disease. And that can show up in many ways, such as swelling in the legs, shortness of breath that suddenly gets worse, depression or pain or problems with your thinking. But the most predominant symptom is breathlessness. And it's usually, when things get very advanced, may become refractory to conventional therapies like inhaler therapies. So all strategies for management of advanced disease and COPD are meant to manage symptoms. The only disease modification that we offer in COPD is smoking cessation, right? But we have little else to actually make the disease go backwards or alter its trajectory completely. So it's very important, especially in COPD, when we're dealing with refractory symptoms, that we find good therapies and treatments to help with health-related quality of life. Some of the studies that we put together looking at physical and psychosocial issues include the universal complaint of breathlessness, but also pain. And, it's interesting because I see a lot of patients. And when they complain of pain and I say, well, yeah, in COPD, you can get pain. I mean, they are, sometimes almost reduced to tears where they say, I was told that nobody understood where my pain was coming, that I shouldn't have pain with COPD. And I want you to know that if you don't have pain, that's excellent, right? If you are worried that you have pain associated with it, you're not alone. 30 to 70% of self-reported patients with COPD will also complain of pain. And that's coupled with physical frailty and the worry that they will become progressively housebound. From the psychosocial side, which I've given an equal arm to, right? Because they're almost just as distressing, right? Once you've had some hospitalizations from COPD, or once you've had conversations that are maybe more serious, some people can get a severe form of anxiety that actually requires treatment, and unless it's addressed and looked at, may never get the proper treatment. So it's very, very important for us to be able to self-identify anxiety and for healthcare professionals to be able to ask you about it. Depression can also occur in up to 70% of people. And there's also the issue of the worry of the person with the illness that their caregiver may burn out, and the actual reality from the caregiver that they are burning out. So what do we do then, right? In breathlessness with COPD, the first thing to do is to make sure we've covered all the bases of what you need to be on, right? To make sure that you're on the correct inhaler therapy, that we review your inhaler therapy, that you're on preventative antibiotics if you need them, that you've had all the support you need if you're thinking about quitting smoking and have not yet, and that you can use the darn inhalers. Because there are some inhalers that if we don't watch people use, they don't get used properly, and that's not helpful, right? Because it doesn't maximize the need that you have in your body for that inhaler. So I get into the habit of watching people take their inhalers and switching them out for an inhaler that might provide equal benefit that's maybe in a different form. And then to understand that if you can't take your inhaler properly, if you can't fully exhale, take a deep breath in and hold your breath for 6 seconds, that maybe the next step should be keeping the same medicine, but delivering them in more of a nebulizer format, right? There are some non-pharmacologic strategies as well. Not everything's in medicine. And there have been several reviews done on how, your home and can be modified for maximizing feeling well. Mainly, they involve temperature control, so cooler temperatures, as well as the appropriate initiation of home supports and gait aids when you need them. So if you need to use a walker for rest, if you need to have oxygen because you qualify for it, if you need a home occupational therapy assessment to help you with equipment in your shower, if you need care aid support to help you hold onto your energy so somebody else can help you get dressed a couple of times a week. These are examples of non-pharmacologic things that we need to be thinking about if people's functional capacity would require us to. The last one in the pharmacologic strategies category I have there is other, the palliative care add-ons that are not directly related to the disease process, but are related to large groups of people for whatever reason they may be breathless. What kind of medications work just for the breathlessness part? There are certain categories that are useful. So benzodiazepines or tranquilizer groups can be used, but mainly for anxiety, not for breathlessness. And painkillers, opiates. That coupled with understanding the need to start an anti-anxiety or antidepressant medication or steroid and antibiotics when needed, okay? I'm going to talk just a little bit about them so that they're familiar to you. So when would it be appropriate to discuss the trajectory of a person, right? Like when do you talk about the natural history of COPD and what it is? I would say at diagnosis, not a doom and gloom conversation, but just like the science of it, what is actually happening, And so what is happening is that people who have any lung disease, such as COPD, will start off here, somewhere in the mid-function of their lives, maybe midlife, and they'll get diagnosed, and that line is it's a plateau. Things are going fine. You've started on your inhalers, you haven't had any side effects, and out of nowhere, there may be an infection, right? And that's the dip. Maybe in a hospitalization, it may mean antibiotics, it may mean prednisone, but you recover, right? And you go back up, back to a plateau. But if you'll notice, the more of these infections that happen, right, and they differ in severity, how low that dip is, right, and how high you come back, what we know is you never quite get right back up to where you started. So that the more exacerbations you have, and you may hear us doctors talk about, time to hospitalization, time to exacerbation, this is why we're talking about it. Because if we can slow down your hospitalizations and your infections, you don't have to worry about going on the downward plateau for a bit. Eventually, every person, no matter what their underlying illness is, right, gets one sort of infection or event that may happen. And because reserve is so poor, because you've been dealing with it for so long, they're at risk of passing away. We don't know when that time is, and certainly not really easily in COPD, because people are amazing and they have great ways of compensating for their lives, and they have great caregivers that care about them. But that's why it's important to talk about trajectory always, because we actually don't know where most people lie on that trajectory. We just know when their function starts to decrease. The It's just very hard to provide that information. So it's an unpredictable disease trajectory. So we need to talk about it early. We don't have to talk about end of life care, but we need to talk about what the natural progression is, right? There have been at least 8 major studies looking at patient-reported symptoms in those troughs and valleys, right, as time progresses. And the things that patients felt like bothered them the most, what bothered them the most in their last couple of years of life. Many people complain of a low level of social functioning, and some of you may feel that now. Many of them complained about the intense breathlessness that they felt was not adequately treated. And many of them said, hey, I don't think I got the supports I needed because I did not know that they were available. And that's the purpose, of today's conversation. It's knowledge is power, right? You need to know what you can get. If you look at the 3 major trajectories, and, I described this one to you, the organ failure one, the cancer one is the easiest one to predict. When that slope off comes, that means that they're predictably unwell. You can measure things, tumor size, protein levels. There are measurables there. And so they often get palliative care introduced early, right? Or at the right time, because there are measurables, right? In our case, when we're dealing with lung disease, it becomes a little bit more tricky, a little bit more of an art form, and a little back and forth, right? Between the healthcare provider and you guys telling us that you need it or want it. So then where do you go? Who's gonna help you, right? So primary palliative care, the beginning stuff, basic management of symptoms, can be done by your family doctor or by any community healthcare team or nurse, okay? And they start with basic discussions about goals of care, prognosis, and how to relieve suffering if you have symptoms that are causing suffering. Specialty palliative care will manage the symptoms that are maybe not getting better with the basic medications that have been started. It will also address management of complex psychosocial issues, anxiety, and grief. If there's any conflict about goals of care or familial strife, we are a team that will include a spiritual care provider, occupational therapist, social worker, so we can deal with the good, the bad, and the ugly, and we will. And then addressing changing goals of care, whether things are valuable to incorporate or not. But there's always challenges to changing levels of intervention or involving a team. In general, you may hear people around you, friends and family, say, well, why are you doing nothing? There's lots of treatments. I heard about this experimental treatment in Oregon. That's where you should be going. And the belief that if you do nothing, it's like a give up, or that you will be in intractable pain or suffering. Sometimes it's religious and cultural beliefs, and that, that is not something that we wouldn't address or respect. And some of it is just complete lack of knowledge about the dying process, the changing process, and the need to be able to ask questions. Healthcare teams can also be less helpful. And that's because of us, we have unrealistic expectations of success always, I would say. There's no greater optimist than a person who thinks they can introduce medications that will make you feel better or live longer. And I promise you, I think most of us would love to always do that. But there's also discomfort in not knowing in the prognosis. Like I just told you how hard it is for somebody to tell you about time. And for a lot of healthcare team members, it's really hard to admit that we don't know. And so we just simply put it off and don't address it. Some of it is complete lack of knowledge or experience that, sometimes your healthcare team just doesn't know what's available or doesn't feel that they have the tools to know what's available, right? Or they have some sort of lack of personal or professional experience with the process that makes it harder for them to discuss. This is what I've learned from the patient's point of view. So most of the patients that I speak to, the people that I speak to who have any trouble with COPD, they're pretty aware about the general state of their performance because they live it, right? They will most times, I've learned my patient population tends to tell me when their quality of life is poor, and I'm so glad they tell me, or tell me when they think, this is too much. I don't want that life-sustaining anything. Just be careful when I go to hospital. I think a lot of people wait for me to bring up the conversation because they kind of don't know how to bring up the conversation. And I know that they look to me for guidance, right? So I should be able to provide that. And the one thing we've learned from study after study, and I am so sorry, caregivers, I know how wonderful you are, but sometimes you are inaccurate about the patient's quality of life, either because you're hopeful or because the person you're caring for is lying to you to protect you. And so sometimes it's helpful to have a practitioner from some supportive place do an independent assessment as well. Maybe they may feel more comfortable telling me that, for example. COPD has a unique burden of challenges, and that is when you get severe COPD, you're kind of always in hospital. So you get the symptoms, you don't have enough time to see your family physician or your respirologist because you have to go to the emerge. You go to the emerge, and then you're discharged home because they put a Band-Aid on it, and they said, well, you no longer have a COPD exacerbation, your pneumonia is clear. You go home, and then you get sick all over again, and the cycle starts. So, when do you start talking about advanced care planning, right? Arguably, it's your home team, like your primary care doctor, your primary respirologist, your primary trustful person in healthcare that addresses that with you, or that you feel comfortable to address with us, because otherwise those needs don't get met. And so the whole purpose of knowing and being aware of what's available to you is to sort of break that burdensome cycle. You can get supportive care in your home at freestanding facilities called hospice, or in an inpatient unit called the palliative care unit. They are part of a pentad, okay? So all of these exist with palliative care services. So if you're in residential care already, if you're in the hospital already, and that's the bottom of the pentagon, then you should be able to receive palliative care where you are from the community team. We have a community home care team and a community referral sheet that any healthcare practitioner can fill out. Hospice is a place in everyone's community where you can live if your care needs exceed what can be delivered at home, in conversation with your primary care team. And the palliative care unit is not a hospice. It's a place where we would admit you if you had really advanced symptoms, we need to give you a lot of medication, or titration was uncertain, and then we decide where you go from there. Can you go back home? And that is basically the same thing I have here, but in written format now. What I mean by advanced care planning, which can be done at any of those sites, is talking about what we talked about today. I'm so sorry, did someone have a question?
Hi, Dr. Nayar. People here just will have to speak through your microphone. Does anybody have any questions? She can only hear you if you're speaking through a microphone.
Yes, I see a question coming.
And please take your mask off if you can.
Okay.
It's hard to hear.
Okay, can you hear me? Can you hear me okay?
I can.
Okay, great. So can anti-anxiety medication cause your muscles to relax too much that it would interfere with your breathing?
You repeat that for me one more time? There was feedback. Sorry about that.
Can anti-anxiety medication cause your muscles to relax too much so that it would interfere with your breathing?
That's a really good question. So in patients with COPD, I try to stay away from the tranquilizers if I'm just treating anxiety off the bat. So for example, many of the antidepressants like citalopram, Zoloft, they will also help anxiety without causing any decreased level of consciousness, okay? So we do have really great pharmaceutical options that will not cause depressed breathing in any way, shape, or form. There are some resistant cases though, and in those resistant cases, I will add a tranquilizer sometimes, but at the lowest possible dose and in very, very careful titration. I would not suggest that people who are unfamiliar with the use of these medications just willy-nilly add them on at all. You know, it should be someone familiar with COPD and familiar with the use of these medications in COPD that should be writing that prescription.
I'll just ask one question. Just if you have any thoughts on if people, first, thank you for such a frank and honest and really helpful presentation. We skipped that part. Just thoughts on how, if people want to think ahead to, a future point when they might need some kind of advanced support or palliative support, are there things that people can do while they're still feeling well to sort of set things up and prepare for the future?
That's a great question. So I ask everybody whom I see, or when they ask me that exact question, there is a website called My Voice BC, and there is an excellent booklet that you can either do online or you can have delivered to your home from the government that offers you these exact exercises in terms of exercises for approaching your family with their questions you have, places where you can write answers down. It has a section where you can identify a substitute decision maker, and it has a goals of care form that you can review carefully, right? And then what I would suggest, just the average person who doesn't, as you're suggesting, maybe doesn't need anything aggressive right now, I would share that with your GP or your primary care provider, and they can take copies of the substitute decision maker form and the goals of care form and keep those for you. And then at least you know that you've had an introduction, right, to the things that are necessary for advanced care planning, right? And somebody like your GP or primary care provider that actually knows what those wishes are. But I think that exercise is useful for everybody.
Actually, that My Voice is excellent. I would give it a 10 out of 10. My hubby passed away here 2 years ago, and we went through that when he was kind of doing better. And we went through it with neighbors, and the neighbors signed it, and he signed it. It was interesting because I said to him, "You want to be buried in Friedenstall?" Because he was Manitoba. He's like, "No." So anyway, he's outside of Abbotsford in Mount Lehman looking at the sky. But anyway, I highly recommend it. It's really simple. And if you do belong to a group, they will come to your group and present, the people from My Voice. They will come and present. So anyway, I'm just going to add to what you said already.
Thank you.
That's a fantastic endorsement. Darcy, did you have a question, or were you just giving it a thumbs up? Okay. Any other again? That was a fantastic presentation. I think a great way to close our talks for today. So maybe we'll just give another round of applause. You might not hear us, but we're all clapping back in there.